Hey guys, for those of you who don't know me, I'm Jane. I'm one of the PGY3s, and I'm going to be giving my admin and policy lecture on crowding in the emergency department. Thought that this was pretty topical considering the last couple of years with starting residency, having high volumes, and then going ahead through 2019 to 2020 with the pandemic and the radical decline in ED visits, and now seeing the increase in patient volumes and us achieving the same volumes we were at before, the same length of stays and waiting times of about 8 hours. I thought it was a good topic to discuss again. Over the last couple of years, from 2019 to 2020, the number of ED visits decreased by about 42% from a mean of about 2 million per week in March of 2019 to a mean of about 1 million per week during the early pandemic period of 2020. Visits declined for every age group, with the largest proportional declines in visits by children ages less than 10 years old, down by 72%, and 11 to 14 years old, down by 71%. And now, we've all noticed, these numbers are rising again. ED crowding is a patient safety issue and a public health problem. According to the CDC, approximately 50% of EDs experience overcrowding, and a third of US hospitals have experienced ambulance diversion. Before we start talking about ED crowding, I wanted to talk about exactly how we measure it. The first way that it's measured is by the NEDOC, the National ED Overcrowding Scale. Elements of the NEDOC score include number of beds in the hospital, as well as the ED, total patients in the ED, number of admits in the ED, number of patients on ventilators in the ED, as well as the waiting time of the longest admitted patient and the longest waiting room patient. Other ways that we measure crowding include the ED length of stay, the rates of left without being seen. Importantly, the patients that leave without being seen are no less sick than the patients that stick around, and the hours of ambulance bypass and diversion. Moving on to the rest of the lecture, I'm going to be talking about the causes of ED crowding, which we separate into issues of input, throughput, and output, the consequences of ED crowding, specifically patient, staff, and system effects, and finally some of the solutions, which include bed management, leadership programs, and nationally mandated patient dispo targets. So first of all, we're going to be talking about the causes of ED crowding, like I said, separated into input, referring to kind of what's going into the system, high volume of low acuity presentations, presentation of more urgent and complex patients, and lack of access to primary care. Throughput, referring to staffing shortages, both in nursing and the presence of junior medical staff in the ED, and delays in test results. And finally, output, getting those patients out of the ER, specifically access block and number of ICU and cardiac telemetry beds. In terms of input, non-urgent visits are often due to a lack of access to primary care. Frequent flyer patients are very common in the ER, and surgical scheduling can increase patient volumes. And then seasonal illness such as influenza season or pandemic can increase input. Studies on the uninsured do not support the contention that they use the ED more than insured patients, or that they're a substantive cause of overcrowding. So it's something that's surprising. I think most of us think that our ER is full because we have a lot of patients that are uninsured and come to the ER for low acuity presentations, but these don't seem to have a significant effect on overcrowding. More recent studies have shown that frequent flyers represent the sickest patients, have the greatest admission rates, highest mortality rates, and consume a disproportionate amount of resources. They account for about 14% of ED visits. So definitely people that you should be looking out for. In terms of throughput, we see this all the time, but inadequate staffing is a significant cause of ED crowding, and increased use of ancillary services such as CT scans can also increase the crowding within our ER. A recent point prevalence study of crowding found that an average nurse was caring for 4 patients simultaneously, and an average physician was caring for 10 patients simultaneously. But these numbers for us are laughable. Our nurses carry much more patients. We tend to carry much more patients than that. And finally, output. We do have significant causes of ED crowding include inpatient boarding and hospital bed shortages. More recently, there's been a far greater emphasis on the boarding of admitted patients as a primary cause of ED crowding. Admitted patients are left in the ER when there's no proper space within the institution. A number of studies have shown a direct and strong correlation between the number of admissions being boarded in the ED and overcrowding, making it clear that this is a significant problem. So really, it's not an ED crowding issue, it's a hospital crowding issue. Next, we're gonna go on to the consequences of ED crowding, which I'm separating into the effects on patients, the effects on staff, and the effects on the system. In terms of patient effects, you see poorer patient outcomes, increased mortality, delayed assessment and care, increased inpatient length of stay, the risk of readmission, and reduced patient satisfaction and exposure to error. In fact, the CDC reported that for patients judged by the triage nurse to be critical, over 10% of this group waited for more than an hour to see a physician. And only 67% of acutely ill patients were seen within a recommended time in the US. For example, there's a significant delay in time to balloon inflation for patients experience an acute MI, which was seen during overcrowding. And when studying the complication rate of patients with ACS as a function of crowded versus non-crowded conditions, there's a significant increase in serious complications, approximately 6% versus 3% incidence of death, cardiac arrest, heart failure, late myocardial infarction, arrhythmias, stroke, or hypertension in those patients presenting during times of overcrowding. A number of articles document the impact of overcrowding on the quality of care and medical error. Multiple studies document inferior care rendered during times of overcrowding. The first paper up there document the impact of overcrowding on the care of asthma and long bone fractures in children. The second article looks at timely provision of analgesia for patients with abdominal pain, which is a recurrent problem that's been documented. Just giving pain meds is very difficult when the ER is overcrowded. And then one American prospective observational study identified an increase in frequency of medication errors, including administration of incorrect and contraindicated medications during times of crowding. Next, we're going to talk about staff effects, which include non-adherence to best practice guidelines, increase in staff stress, obviously as a result of that, and increased violence towards staff. For example, for patients with NSTEMIs, long ED stays were associated with decreased use of guideline recommended therapies and a higher risk of recurrent MI. And as ED volume increases, ED patients diagnosed with community-acquired pneumonia are less likely to receive timely antibiotic therapy. Moreover, studies have shown an increase in the rate of violence towards staff on higher occupancy days in the ER, which we see ourselves all the time. Next, we're going to talk about system effects, which include increased inpatient length of stay. One article looked at the outcomes of ICU patients subjected to a delay of greater than 6 hours to transfer to an ICU and found an increased hospital length of stay from 7 versus 6 days and a higher mortality rate, 10.7% versus 8.4% for those patients. And then there's also an increased emergency department length of stay. Another article found an increasing mortality rate and increased length of stay as a function of how long the patient boarded in the ED. The mortality rate was 2.5% in those who boarded 2.5% in those who boarded for less than 2 hours, and increased to 4.5% for those boarded for greater than 12 hours. Similarly, length of stay increased from 5.6 days to 8.7 days. And then finally, I'm just going to talk about solutions very quickly. These are things we think about all the time, but there's also things we've seen in practice. In terms of increased resources, all of us would think that increasing access to primary care for lower acuity visits would decrease crowding, but like I had mentioned before, lower acuity visits and lack of access to primary care hasn't been shown to be a primary cause of overcrowding. So it's more just increasing resources within the ER that's going to help with reducing overcrowding. This includes things like the addition of a hospitalist to focus on bed management, which we have over at Kings County. We have our PIC. And so for that, like a recent study has shown that the hospitalist's role is to decrease throughput time for admissions by up to 100 minutes, and also resulted in a decrease in ambulance diversion. Things like a provider in triage, we see that as well, has been offered as a potential solution. Hasn't necessarily been proven to be effective, but is definitely a useful tool. And then provider schedule optimization, having more providers in the ER during busier times will definitely help with throughput and be like a form of increased resources. Increasing nursing staff, whether that's by floating nurses to the ER or having surge nursing, which we had during the pandemic, can help with getting patients out of the ER as quickly as possible. In terms of demand management, a few things have been suggested, and there's definitely a lot more. But there's one proposed solution is moving ED hallway patients to inpatient hallways. This studies have shown that this actually increases patient satisfaction. Patients would prefer to be in a hallway in an inpatient unit rather than the hallway in the ER, I guess. Other options are trying to help with our early discharges. According to one study, early discharges would decrease boarding by 96%. Seems intuitive, but still, at NYU, increasing the number of patient discharged before 12 p.m. resulted in overall decreased length of stay. All pretty intuitive, but things just to push for. And then increased weekend discharges. This is kind of difficult because we don't have a lot of the services that we need, such as echo and MRI, stress testing on the weekends, but by simply redistributing the staff that are available on the weekdays to the weekends, we could potentially decrease our crowding within the ER and not necessarily have to increase the staff. And then finally, things that were suggested by like Swedish studies and stuff like that is decreasing decreasing diagnostic testing within the ER to get patients out of the ER faster. Then finally, we're just gonna be talking a little bit just about operations research, what people are doing right now to figure out what works to decrease ED crowding, specifically PDSA cycles, which are plan, do, study, and act. And these kind of work to implement changes on a small scale to figure out if those things will work in the future. There's plenty of PDSA cycles. I'm not going to talk about them now. I've read about a couple that specifically target junior staffing and how to help with throughput when junior staffing kind of slows things down. And then, so just quickly a summary, so that we're aware, there's no evidence that overcrowding results from excess poor patients or non-urgent visits. It's not due to decreased access to primary care. ED crowding causes a variety of problems, most important of which is poor patient outcomes. And then finally, you have to think about ED crowding as not just as really hospital crowding, and solutions should be geared more towards that, getting patients out of the hospital rather than necessarily out of the ER. Okay. Thank you.